Thanks, Charlie, and to all of the organisers for inviting me to speak today. I'll briefly start by explaining how it is I've come to be speaking to you about this topic here. As Charlie said, I'm a consultant in metabolic conditions at the John Radcliffe Hospital in Oxford. But as will already be becoming apparent, I don't have a classic Oxfordshire accent, nor Cotswolds, nor even southeast of England. I'm from a wonderful part of the country in Scotland, just southeast of Glasgow, known as Lanarkshire. And I was growing up there where my interest in this topic began. My first memory almost of running and a lifelong obsession with athletics was this 100-metre final at the Olympic Games in Seoul in 1988. And I'll come back to that race later. It became somewhat notorious. I confidently explained to my parents that I would be becoming a 100-metre runner, despite my very skinny arms and skinny legs. But they humoured me and took me along to this place. This is an athletics track in a town called Wishaw in Lanarkshire, where I would run round and round that track, as I'm sure many of you do. I think my conclusion is that for what most of you are doing tomorrow is approximately 41.8 kilometres further than it needs to be. But we had some high-level athletes and some national, international level coaches. And one of the coaches always used to say to us, in Britain, we have the best athletes in the world drug-free. And he would always put that phrase in, which piqued my interest in these types of topics. I moved through a clinical career, and I've had the chance to work in several academic projects looking at doping and developing testing to try and stop athletes from taking performance-enhancing hormones and supplements. And then more recently, my clinical work has involved me getting involved in cases where normal runners, recreational athletes, members of the public have been making themselves severely unwell, coming into hospitals with the complications of trying to manipulate their hormone balance. And so I'll give you a couple of cautionary tales today. I'll explain how it is we might have come to be in this situation where people are taking things from unknown sources and making themselves unwell, and then what the future problems in that area might be. The first case I was involved in over the last couple of years, this 32-year-old man presented to our local hospital. He worked in IT, he'd previously been completely well, but he'd been having investigations over a few years for a condition called polycythemia, where his hemoglobin was raised. It was well above the reference range at times, and he also had a raised hematocrit. And he was having lots of investigations, seeing lots of different specialists after having seen his GP about this. He had quite invasive things performed, such as a bone marrow biopsy, genetic testing, but no underlying cause had been found for his polycythemia. Throughout the history, you can see through his notes that he was mentioning that he took workout supplements. He'd been a very high-level athlete in cross-country, track and field and rugby in his teenage years, had moved on to just recreational 5-kilometre and 10-kilometre running. But over the couple of years before presentation, he'd been increasing his gym attendance up to 6 or 7 times per week. He'd been participating in events such as CrossFit training. Things were getting worse over the months, and he started having to see the vascular surgeons. He was getting intermittent claudication in both legs. That's a sign of ischemia to his feet and to his lower legs, and he needed this investigation, a CT angiogram of his lower limbs and his aorta. And he'd really got quite severe disease that showed up on these investigations. He'd occluded almost every artery to both of his lower legs, and there was thrombus and evidence of dissection in his descending thoracic aorta, so very severe arterial disease. He then needed to be admitted and had a long admission in hospital because he developed severe critical ischemia in both of his feet. He was needing long-term anticoagulation, and the vascular surgeons were even considering amputating one or both of his feet at this point. Each of the teams that met him, the hematologists, rheumatologists, immunologists, and cardiologists would all ask about his workout supplements because everyone is aware that they could be an underlying cause of this polycythemia. And there started to be some confusion about what supplements he was taking, when he had started, and indeed when he had stopped taking all of these. So at some point he produced a bag of some of the things he was taking. I mean, many of these things are very commonly used by a mixture of strength athletes, endurance athletes. There are protein isolates, dextrose, creatine, and magnesium, some of which we'll come back to. But really none of this explained the severe nature of his arterial disease or the progression. And as always, we often get much more history from patients' family members. In this case, it was his partner that arrived at the nurse's station with a revealing bag of supplements. And indeed, these aren't the ones he was taking, but very similar. He was actually, for many months, if not years, he'd been taking intramuscular testosterone injections. He'd been taking synthetic steroids in the form of nandrolone and methanolone. And actually, simultaneously, which really helped in this case, we'd sent off urine samples to my colleagues at the anti-doping laboratory. This building belongs to King's College London. It's just down the road from here, and it houses the UK anti-doping WADA-accredited laboratory, runs all of the anti-doping testing for Britain and for much of Europe. And they'd found a real cocktail of drugs, evidence of stacking of anabolic steroids in this gentleman's urine that really explained his presentation. We'll come back to some of the complications later. A second very similar case we published in BMJ case reports. This one was from Bath, where a young man, a 34-year-old man who'd again been completely well, was diagnosed with an acute stroke after presenting with confusion and evidence of right-sided visual loss. Again, he was seeing multiple teams over a week of investigations because it was unclear why this such young man, who was so well, had such severe arterial disease to cause a stroke. And once again, it became apparent after extensive questioning that he was on repeated cycles of some of these substances. He was taking testosterone and trenbolone. And interestingly, he was also following up his steroid cycles with post-cycle therapy. These are selective estrogen receptor modulators such as tamoxifen and clomiphene, used to try and restart our endogenous hormone production and to try and mitigate some of the side effects of steroids as well. And in a third very recent case, this was I was working on with our local endocrinology team, and they explained to me that this is a very typical presentation that they're seeing a lot at the moment. A gentleman had been seeing his GP 12 months previous, lots and lots of times, because he was suffering from excessive fatigue. He wasn't recovering from his sessions. He was a 10K runner, endurance cyclist, and he just felt he wasn't recovering properly or as well as he used to. His libido was reduced. He was describing brain fog and some other vague symptoms. The GP had done a whole panel of tests, including hormones such as testosterone and androgens. All of these were normal. But at some point, the history often gets confused in these situations. He'd gone to see his local hormone replacement, testosterone replacement therapy service via the internet. And we don't have all of the results. Some of the testosterone samples were sent off to the States and even have different units, different cutoffs by which they would measure things. But he'd been prescribed a testosterone intramuscular injection to take weekly at 200 milligrams. It was unclear whether he'd fit the real clinical indications. When our endocrinologists start testosterone therapy here, they're very strict about patients fitting the clinical symptoms of testosterone deficiency alongside some very strict cutoffs that they would like to see before they start patients on testosterone. But what was clearly happening is he was suffering the side effects of many of the side effects of taking androgen or testosterone therapy. He again had a polycythemia, which could have increased his clotting risk with risk of arterial disease. He now had a significant hypertension that was sustained alongside an abnormal cholesterol and triglyceride profile, suggesting his cardiovascular risk was significantly increased. His prostate-specific antigen level was high. That could be a sign of prostatic hyperplasia and could be a risk factor for future prostate cancer. His mood had changed with irritability and anger, and they'd also found evidence from the blood test now that he'd suppressed his pituitary hormones. His endogenous axes were not working properly, and he was also describing and on examination had evidence of testicular atrophy. So just these three short cases makes us all wonder, how have we got to the situation where members of the public are happy to risk having their legs chopped off, losing function, motor function on one or other side of their body, or increasing their cardiovascular risk? How have we come to this and with such ease of availability of these substances? Well, I think we as recreational athletes have always learned from the elite athletes. And so just a brief history of how we've got to this situation of doping, of using performance-enhancing agents. Even the ancient Greeks were interested in performance enhancement. They used all manner of figs, plums, prunes to try and improve their performance in the ancient Olympics. And another old story is this gentleman, Thomas Hicks, was the winner of the 1904 Olympic marathon in severe heat conditions in St. Louis. He prevailed despite extreme conditions. It turned out subsequently that his team that are supporting him there had been keeping him going through the race with a mixture of brandy and strychnine. Strychnine is a potent alkaloid poison that's used in pesticides. At even moderate amounts it could be fatal, but at very low doses that they were giving him mixed with alcohol, it had a stimulatory effect, and he managed to win this race. We move forward to what we'd all regard as the common stories of doping. Through the 70s and 80s, the bodybuilding industry saw the benefits on lean muscle mass increase, on decreasing fat mass, and producing this physique that would allow them to compete in bodybuilding competitions. And alongside that, there were textbooks and guidelines being written to try and help members of the public take anabolic steroids safely and to try and decrease some of the side effects. The race that inspired me to become obsessed with athletics is now known as the dirtiest race in history. The winner there, Ben Johnson, in a world record time, was later found to have been going through years of anabolic steroid misuse along with his group. But actually almost every competitor in this 100-meter race has since been embroiled in some form of doping scandal or has had a positive doping test. Things moved forward through the 90s as pharmaceutical preparations of testosterone and similar agents became much more widely available. They also immediately became available on the black market, and they were starting to be used in a wide variety of professional sports, through the Tour de France scandals, also throughout athletics and in many other power sports. Things moved on again. I think the athletes and their support systems were getting clever, more and more clever. In the 2000s, the Bay Area Laboratory Cooperative, or BALCO scandal. This was a nutritional supplement company that was marketing its nutrition to elite athletes, including the world record holder in the men's and women's 100 meters. But actually what they were also being given was a group of very cleverly manufactured steroids there on the right-hand side. The most popular of those was THG, tetrahydrogesterone, and they'd realized that if they just move a double bond or a hydroxyl group, they can gain even better anabolic properties than from endogenous testosterone, but these substances were very difficult to detect in urine or blood samples. Jumping forward to the state of this in the UK, the answer we always give is we really don't know the prevalence of anabolic steroid misuse in this country, or indeed in many countries around the world. This group I've worked with in the past in Leeds and West Yorkshire have really been at the forefront of trying to discover more about anabolic steroid use here, and they've even set up a clinic to try and help anabolic steroid users do things safely with endocrine monitoring. Here we were publishing some kinds of guidelines to try and help GPs with which testing might be useful if they suspect one of their patients is taking anabolic steroids. We know that recreational and elite athletes are taking anabolic steroids and similar agents for image enhancement and performance enhancement. That estimate in 2016 of 270,000, we know it's much higher than that, probably well above 500,000 users of anabolic steroids in England and Wales nowadays. And other things we're realizing is that customs are telling us there's an increasing number of shipments that are being seized at our borders. Needle and syringe exchange programs are describing that anabolic steroids are making up a larger and larger proportion of their workload. And we also know that athletes, both recreational and elite, don't stick to clinical guidelines. They're taking steroids and other substances at doses that are far in excess of what would be used by a clinical endocrinologist with the risks attached. I've already described some of these. They certainly have an increase in cardiovascular disease as a risk factor from anabolic steroid use, probably 5 times the risk of cardiovascular or events or stroke. They increase our chances of clotting, and that can increase the chances of venous disease such as deep venous thrombosis or pulmonary embolus, and they can also have an increased risk of cardiomyopathies, sudden arrhythmia and sudden cardiac death. I mentioned the estrogen receptor modulators. They add an even further risk of increased coagulability and clotting disease. And what we're worried about in the long term are some of the effects on the endogenous hormones. If you take a synthetic anabolic steroid, you will certainly suppress your endogenous hormone productions from the hypothalamus and the pituitary gland. That can lead to some of these complications such as testicular atrophy, a phenotypic change, gynecomastia, where male patients are developing breast tissue due to an imbalance between their testosterone and androgens and their estradiol and other estrogens. And then in the long term, the most worrying feature could be an impairment of fertility from taking anabolic steroids over long periods of time. So far, I've just discussed steroid hormones. The other big group of hormones that are abused for their anabolic and lipolytic properties are the peptide hormones. And I joined a group in the 2000s in Southampton and at King's College London that were interested in the effects of growth hormone and related factors on athletic performance, and whether we could develop tests to try and stop elite athletes from taking these. So the growth hormone axis is, along with the growth hormone releasing peptides and insulin-like growth factor 1, IGF-1 from the liver, they have potent effects on muscle, on tendons and ligaments. They have potent anabolic effects. They also act on adipose tissue to cause lipolytic effects. So athletes are looking for that perfect balance of being able to maintain an optimal strength to weight ratio using some of these hormones. The question has always been, unlike anabolic steroids where the beneficial effects were clear, does growth hormone improve athletic performance? We had many years of experience treating growth hormone, using growth hormone to treat growth hormone deficiency in clinically deficient patients, and it certainly had beneficial effects on their lean muscle mass, on decreasing the adipose tissue, on increasing their VO2 max and aerobic endurance. But for example, a systematic review in 2008 could not find evidence that growth hormone enhanced physical performance in normal, healthy athletes. We've since had quite a lot of evidence that in fact growth hormone is a really beneficial substance if you want to increase your athletic performance. This study was performed in Sydney in around 2010 and was one of the most important to show that growth hormone has beneficial effects. Around 95 recreational athletes were given combinations of placebo injections, growth hormone, testosterone, or a mixture of these injections. And they looked at a variety of performance variables. The graph shown here on the y-axis has the change in wind gate value, which is a measure of sprint capacity or power. And those athletes that were taking growth hormone certainly had a significant increase in their wind gate sprint capacity. And if they took growth hormone and testosterone together, the effects were combined and they had an even more potent effect on their sprint capacity. Our group were also interested in the effects of insulin-like growth factor 1. It was already becoming a popular substance of abuse. It was available on the internet both as a pharmaceutical preparation and in substances such as that one on the right. It's called deer antler spray. It's meant to have extracts from deer antlers that should contain IGF-1. We took 56 recreational athletes. We asked them to inject recombinant IGF-1 for 28 days. Really, the focus of the study was to try and develop biomarkers and detection methods for IGF-1 misuse in elite athletes. But what we could also do is estimate the changes on body composition using DEXA scanning and on physical fitness using this graded exercise treadmill test. After a month of injections of IGF-1, we couldn't show any improvements in body composition or changes in body composition. They had a small but significant improvement in their VO2 max, but we always had to have the proviso that the doses of IGF-1 that we were using were clinical doses used in IGF-1 deficiency. Athletes we knew were using far more significant, higher doses of IGF-1 than we could use in our trial. The current state of play, well, really we don't know. We know that athletes on bodybuilding blogs and various other fitness forums, they talk about growth hormone a lot and related factors. They are worried about the long-term side effects of these types of hormones. Growth hormone, again, like steroids, can have an effect on the heart muscle and cause cardiomyopathy. It can lead to glucose intolerance and potentially diabetes, and there's thought to be a potential increased risk of cancer with long-term growth hormone excess. But we also, on the other side, have famous actors such as Sylvester Stallone telling the public that he thinks every man over the age of 50 should take growth hormone in order to maintain lean muscle mass. We have shipments of growth hormone regularly seized by customs, so we know it is still a substance of misuse. And the current state of play, what's happening? Just a very brief case, final case to illustrate this. This was in the last few weeks. This 38-year-old man, since last Christmas, had really been trying to go on a fitness schedule. He was dieting. He was trying to improve his 5-kilometer time. He says he'd lost 10 kilograms. We suspect he'd actually lost more than that and had actually had to start eating more to try and put some weight on. And he hadn't started from a very high BMI when he'd started on this fitness regime. He'd now come to see his GP. He was actually very unwell, was immediately admitted to hospital, passing lots of urine. His vision was blurred. His GP had checked his renal function and he had evidence of a very severe acute kidney injury. His creatinine was as high as 500 compared to a baseline of around 70. And when they did this bedside urine dipstick test, it had both blood and protein in the urine. signs of very severe kidney injury. He also had a very significant hypercalcemia. That's a high calcium level in his blood, around 4.5, and a normal level is around 2.4. And so again, he had some very severe clinical complications. Over about 48 hours, he met lots of clinical teams. They assessed him, asked him lots of questions. And even the renal physicians were considering having to start dialysis on this gentleman. Again, through one of the sets of questionings from one of the clinical teams that the gentleman happened to mention, he'd actually also been taking a number of recreational drugs. He'd previously taken testosterone for bodybuilding. He'd previously been taking Mounjaro to help his weight loss. And then more recently, he'd found a couple of preparations on the internet. He was taking a very high dose of vitamin D injection at 600,000 units every couple of weeks. Just to put that in perspective, if a patient's, to try and maintain normal bone health, we try and suggest a dose of around 800 to 1,200 units daily. This gentleman was taking huge doses in excess because he thought it would improve his muscle function and therefore improve his athletic performance. And that certainly explained his very high calcium levels in his blood, and probably explained, therefore, the reason for his acute kidney injury. But this gentleman had also managed to find on the internet this very new drug, retatrutide. It's not even available pharmaceutically. It is the next weight loss drug that's going to be coming out probably in the next couple of years. He was able to get this from an unknown source on the internet. The retatrutide is known as the Godzilla of weight loss. It's known as the triple G of weight loss because it's taking on, the three Gs refer to these three hormones: the glucagon-like peptide-1 agonist effect, the glucose-dependent insulinotropic polypeptide, the GIP effect, and glucagon-like effects itself. So those are the three Gs that retatrutide contains. And for the purposes of this gentleman and for this talk, he's interested in the effects that can have on stomach emptying, these slow stomach emptying, so they increase the feeling of satiety and fullness so that we eat less. It stimulates insulin release. The glucagon has various effects, including a lipolytic fat-burning effect on adipose tissue, and they all act centrally on our appetite centers to decrease appetite. And so we know that all of these drugs, particularly the GLP-1 agonists that we know most about, have potent effects on weight loss. This is the Gila monster, the venom of which provided the original compounds that allowed the original GLP-1 agonists to be developed. And we've been using these for many years. We can't now go a day or a week without a news story about the miraculous effects of the GLP-1 agonists. This is the recent Netflix documentary on the Ozempic effect. Ozempic is the form of semaglutide that's marketed as a GLP-1 agonist for weight loss in America. The UK version, Wegovy, is the same medication being marketed for weight loss. And then obviously over the last few years, we've had the addition of Mounjaro, which combines the GLP-1 agonism with GIP effects for an even greater effect on weight loss. The question for today is, do the GLP-1 agonists have any effect on physical fitness? I think the jury is still very much out. This was a review from last year looking at all the studies that have looked at the effects of GLP-1 agonists on aerobic performance in terms of VO2 peak. It's been very difficult to show that there is an increase in VO2 peak secondary to GLP-1 agonist use. In some studies, there have been a small increase in VO2 peak after GLP-1 agonist injections, but these have been in patients with, for example, heart failure or quite severe obesity, and that we don't know how that translates into people with healthy BMI or who are just slightly overweight. And the other thing is the obvious and now becoming well-known side effect of all of these methods for quite significant weight loss. Although they're all showing very good weight loss effects, up to 15-20% in some studies. Some of the larger trials in semaglutide have then looked at the amount of lean muscle mass that's being lost, and that is significant. In some cases, the proportion of lean muscle mass is up to 45% of the overall weight loss. And so I think at the moment we'd say that the GLP-1 agonists and related compounds, we're not sure that they have clear effects on aerobic endurance in patients with diabetes, patients with obesity, and certainly not in healthy people that are taking GLP-1 agonists. We do see that there are prominent YouTubers who are promoting the use of GLP-1 agonists to try and help even recreational athletes. But we do know that they're going to have effects on your lean muscle mass, and we need to worry about that. And I think the services that are promoting these and prescribing these are noticing that, and they're starting to also think about counselling their patients on an exercise program alongside GLP-1 agonist use, both aerobic exercise and resistance exercise, to try and maintain that muscle mass. What's next and what else I haven't been able to cover, there are hundreds of supplements that are available on the internet that we know people will take, they will try, and they'll see what effects it has on their own performance. At the bottom left, IV infusions of vitamins, of carnitine, and also amino acid supplements. I really can't find any evidence that that's going to provide a performance for a marathon runner over and above a healthy diet with a reasonable amount of protein and nutrients and vitamins. We have at the top left sodium bicarbonate. Yeah, it has good effects on buffering lactic acid, probably more useful in the high-intensity exercise events, 400 meters, 800 meters, but also in interval training. And creatine we've known for many years. It possibly is it's a very safe form of supplement, and it has good effects on being able to recover from all types of exercise training and allow you to exercise at a higher intensity subsequently. So again, we've got a very interesting couple of months coming up. You'll have heard of the Enhanced Games. It's having its inaugural event in Las Vegas next month. These are current or ex-elite athletes who are going to be participating in sprinting, swimming, and in weightlifting. And they've been going through a program of hormone enhancement, including growth hormone, anabolic steroids, and other banned agents. But they're being supervised by a group of sports scientists, endocrinologists, and other medics as they go through this program before they compete next month. I think from our side, from the anti-doping world, it's going to be interesting to look at the changes in performance now that we know that these athletes are definitely taking some of these substances and compare those with their pre-enhanced performances. Conclusions, I think all I can conclude is that we know that both elite and recreational athletes are going to continue to try these supplements, their hormones. They're going to try every means they can to enhance their performance. I hope from some of the cases I've shown that some of these risks are real and could be clinically severe, and the NHS is starting to see some of that and recognise that anabolic steroid abuse is a significant problem. But a lot of the long-term risks remain to be confirmed, including things like fertility in the future. I thank all of my colleagues in Oxford, including the patients who were happy for us to try to present and learn from their cases, and all of the people and teams I've worked with at the University of Southampton on the Growth Hormone Project and at King's. My last slide, I think, as Charlie mentioned, I was interested to see that this is Lightning the robot that won the Beijing half marathon very recently. I think when the robots are giving this talk in 10 years, and possibly when the robots are sitting in the audience, I can't imagine they'll be interested in anabolic steroids, in GLP-1 agonists, or in growth hormone. I think they'll have switched their focus, but I think performance enhancement will still be a thing of the future. We'll wait and see. Thank you for your attention. I'll take any questions.
Fascinating and frightening in equal measure, I think. Any questions? I'm sure there's hundreds of questions. We do have time for a couple, so yeah, one at the back over there. Yeah.
Hi, thanks for the great talk. So regarding the GLP use, so we know that with the long-term use, we have this, with the extreme weight loss, we have this lean muscle mass reduction as well. But what's your take on the quality of the muscle, like the remaining muscle?
So I think what we're seeing is that the quality could be improving. So the fat content or the fat mixture of the muscle is also decreasing. And so while there's a decrease in total lean muscle mass, almost certainly, because there is with all of the calorie restriction, the quality could be improving. And that probably will help to maintain muscle function to a certain extent. But I think maybe the quantity of muscle mass is still going to be a problem, which is why, but I think it can be rectified with at least some kind of exercise program alongside GLP-1 agonism. The other thing about the quality is we're seeing once the people or patients have stopped taking the GLP-1 agonist, as the weight comes back on, it possibly comes on in a different fashion, and that then the quality of muscle mass regain isn't what we'd hope for as the fat mass regain. So that could be another problem if people stop taking these agonists.
I noticed all those examples were male. Have there ever been any cases presented from females?
So our endocrinologists are also reporting female cases. So testosterone use is becoming increasingly used in women. And so the main thing they're worried about is the effects on fertility. And so our local endocrinologists have have started contacting us about several female cases with mildly raised testosterone, but certainly higher than the female reference range, who are presenting with infertility or difficulty getting pregnant, but have been taking testosterone for some time. And I think it's going to be quite difficult. I think we're hearing more about it in a later talk. I think that balance is going to be really interesting. Anabolic steroid use is a predominantly male problem at a recreational athlete level. And maybe we have the advantage that I think women are quite worried about the side effects of the type of muscle, the physical appearance. But it's not exclusively a male problem. We know that there are lots of recreational female athletes that will take, say, smaller doses of anabolic steroids as well, including in this country.
Okay, we'll leave it there. So thank you very much, Nishan, for